Hello and welcome to the topic Megaloblastic Anemia in the Haematology module. By the end of this topic, you should be able to define megaloblastic anemia, explain the pathophysiology of this type of anemia, outline the causes of megaloblastic anemia, outline the classification of megaloblastic anemia, describe the clinical manifestations, outline the investigations that can be done, discuss the principles of management and the complications as well as the prognosis of megaloblastic anemia. Let's get started. Let's begin by defining what is megaloblastic anemia. The term megaloblast refers to morphologic abnormality of the red blood cells and its nucleus, specifically the fact that they are large nucleated red blood cells. Megaloblastic anemia basically encompasses a heterogeneous, meaning a diverse group of anemia, characterized by the presence of megaloblasts in the bone marrow. Before we talk about the production of megaloblasts, let's understand more about the process of erythropoiesis, which is the formation of red blood cells. Erythropoiesis is the process where new erythrocytes or red blood cells are produced. These new erythrocytes would replace the oldest erythrocytes that are phagocytosed and destroyed each day, making up approximately 1% of our red blood cells. There are few vitamins and minerals that are crucial in the process of erythropoiesis, namely iron, folate, and vitamin B12. Folate and vitamin B12 are required for the proliferation of erythroblasts during their differentiation phase. A deficiency in either folate or vitamin B12 would inhibit purine and thymidylate synthesis, which in turn impairs DNA synthesis and causes erythroblast apoptosis, resulting in anemia due to ineffective erythropoiesis. Now, this condition is due to impaired DNA synthesis, which inhibits nuclear division. However, cytoplasmic maturation, which is mainly dependent on the synthesis of RNA and protein, would be less impaired. Therefore, there will be an asynchronous maturation between the nucleus and the cytoplasm of the erythroblast, explaining the large size of the megaloblasts. Moving on to the various causes of megaloblastic anemia, we have deficiencies in folic acid, in vitamin B12 as mentioned earlier, and they are the leading causes of megaloblastic anemia. Folic acid deficiency may be related to decreased intake as seen in malnutrition or alcohol use disorder, increased demand, particularly in pregnancy hemolysis, hemodialysis, and malabsorption. Vitamin B12 would most frequently be caused by vitamin B12 deficiency would most frequently be caused by pernicious anemia caused by autoimmune gastric atrophy, leading to decreased production of intrinsic factors. This may also be due to ileal resection, gastrectomy, ileitis of any cause such as Zollinger-Ellison syndrome, fish tapeworm infestation, blind loop syndrome, and pancreatic insufficiency. So in cases where there is decreased amount of intrinsic factors present or produced, this then impairs the absorption of vitamin B12 in the terminal ileum. Another cause of megaloblastic anemia would be copper deficiency, and this can cause a microcytic, pneumochromic, or macrocytic anemia and neutropenia. Copper deficiency also causes myelopathy and peripheral neuropathy. In some rare cases, megaloblastic anemia may be due to inherited problems such as thiamine-responsive megaloblastic anemia syndrome, which is an autoimmune recessive disease characterized by megaloblastic anemia associated with diabetes mellitus and early onset sensory neural hearing loss. Other examples include inherited deficiencies of intrinsic factors of the receptor in the intestines or congenital folate malabsorption syndrome as seen in some infants. Besides that, drug-induced megaloblastic anemia can occur from a variety of different medications via various different mechanisms, either causing cobalamin deficiency such as metformin and proton pump inhibitors, or folate deficiency such as seen with the use of tetracycline and methotrexate. Now, let's take a look at the clinical manifestations, beginning with the symptoms. So one thing you should remember is that symptoms are present only in severely anemic patients, and these patients would come in with complaints of weakness, shortness of breath, especially with exertion, lightheadedness, palpitations, loss of appetite, weight loss, nausea, constipation, a sore tongue, and chancre sores. Another thing to bear in mind is that there would be some minor differences between the clinical manifestations caused by cobalamin and folic acid deficiency. In vitamin B12 deficiency, patients may present with neurological manifestations, where the main symptoms are paresthesia and balance disorders. They may also present with lancinating pains causing peripheral caused by peripheral neuropathy, mainly affecting the lower extremities. Furthermore, there may be psychological disturbances that could include a form of dementia. Pernicious anemia frequently has associations with other autoimmune conditions such as vitiligo, autoimmune thyroid disease, and type 1 diabetes mellitus. Once again, patients may be asymptomatic when it comes to the clinical manifestations if the anemia developed gradually and it was compensated. In cases of severe anemia, however, there would be a few observable signs. On taking the patient's vital signs, you will notice that the patient is dyspneic and tachycardic, indicating possible cardiopulmonary distress. On examination, the patient will appear pale, jaundiced due to intramedullary hemolysis, having splenomegaly, and glossitis due to the loss of papillae. Dermatologic signs include hyperpigmentation of the skin and abnormal pigmentation of hair due to the increased synthesis of melanin. There may also be signs of neuroirritability, psychosis, peripheral neuropathy, subacute combined neurologic degeneration that occurs in cobalamin deficiency, as well as abnormal gait, loss of balance, speech impairment, blindness, and loss of proprioceptive and vibratory senses. If you notice any abdominal scars, you should suspect a gastric surgery done due to blind loop syndrome or a lack of ileal absorption of cobalamin in a patient who had an ileal resection done. Those with non-tropical and tropical sprue may have signs of malabsorption such as weight loss, abdominal distension, diarrhea, and steatorrhea. These patients will have often metabolic diseases or bleeding resulting from deficiencies in vitamin K dependent factors. Patients who have megaloblastosis as a result of HIV infection or myelodysplastic syndromes usually have signs of these disorders. And children with inborn errors associated with folate and cobalamin deficiencies may also have signs of these hereditary disorders. Now let's take a look at the investigations that can be carried out. So the initial workup for megaloblastic anemia should include a full blood count in which you will see reduced hemoglobin or hematocrit with an increased MCV or mean corpuscular volume. You'd also need to get a peripheral blood smear done where you'd see macroovalocytes, single and multiple whole jolly bodies, and nuclear fragments which may be seen in red blood cells. Nucleated red blood cells and megaloblasts and hypersegmented neutrophils can also be seen. Next, the reticulocyte count would be inappropriately low, representing the lack of RBC production due to massive intramedullary hemolysis. In addition to that, LDH levels should be measured. Typically, in the case of severe megaloblastic anemia, the LDH levels would be markedly increased. In addition to that, you should order indirect bilirubin levels, iron and ferritin, serum cobalamin, serum folate, and possibly red blood cell folate levels. Generally, a bone marrow aspiration is not required to make the diagnosis of vitamin B12 deficiency. However, it can help rule out myelodysplasia and assess iron stores. Serum homocysteine and methylmalonic acid or MMA levels are helpful to confirm cobalamin and folate deficiencies, with both levels increased in cobalamin deficiency but only homocysteine is increased in the case of folate deficiency. And lastly, radiographic imaging of the upper and lower gastrointestinal tract may be useful for detecting abnormalities that could cause a blind loop syndrome. Now let's take a look at the medical management. First things first, you need to rule out myelodysplasia related megaloblastosis as well as any drug-induced megaloblastic changes. Once that's done, most patients would either be treated with cobalamin or folate. Due to the fact that megaloblastic anemias usually develop gradually, many patients adjust to low hemoglobin levels and do not require any transfusions. Hence, transfusion therapy should be restricted to patients with severe, uncompensated, and life-threatening anemia. For prescribing cobalamin therapy, prescribe 1,000 micrograms intramuscular cobalamin given daily for 2 weeks and then weekly until the patient's hematocrit value is normal, then monthly for life. Any patients with mental or neurological impairment due to cobalamin deficiency should be treated more aggressively, so 1,000 to 2,000 micrograms of oral cobalamin can also be co-administered. In fact, oral cobalamin is better tolerated by patients and is indicated in patients with hemophilia to avoid bleeding from intramuscular injections. In the case of folate therapy, 1 to 5 milligrams of oral folate should be administered daily. 1 milligram per day is the usual dose for adults with megaloblastic anemia, while a higher dose is indicated in the setting of hemolysis, malabsorption, alcoholism, or exfoliative dermatitis. Folate should also be administered prophylactically during pregnancy, lactation, and the perinatal period, as well as in elderly people. If administering oral folate proves to be difficult, comparable doses can be administered parenterally. And in addition to that, patients should also consume a folate-enriched diet. The most concerning complication of patients with megaloblastic anemia secondary to pernicious anemia would be gastric malignancy. The incidence of gastric malignancy in patients with pernicious anemia was reported as 0.27% per patient a year, and there was a 7-fold relative risk of gastric cancer in those with pernicious anemia. According to a study done in 2018, folate deficiency increases the risk for cancers of the head and neck, oral cavity and pharynx, esophagus, pancreas, bladder and cervix. Generally, the prognosis is favorable if the etiology of megaloblastic anemia has been identified and treated appropriately. However, patients are at risk for hypokalemia and anemia-related cardiac complications during therapy for cobalamin deficiency. In addition to that, folate deficiency during pregnancy can lead to neural tube defects and other development disorders in the fetus. However, the incidences of these morbidities have been greatly reduced by the intake of folate in the form of prenatal vitamins given during pregnancy. Now, let's summarize what we have covered so far. Megaloblastic anemia encompasses a heterogeneous group of anemia characterized by the presence of megaloblasts in the bone marrow. This condition is primarily due to impaired DNA synthesis, which inhibits nuclear division. Both folate and cobalamin deficiency are the leading causes of megaloblastic anemia. Some inherited disorders and drugs may also cause megaloblastic anemia. Clinical manifestations of megaloblastic anemia are usually only seen in severe cases in the form of anemic signs and symptoms, as well as neurological deficits. Important investigations to order include full blood count, RBC indices, peripheral blood smear, reticulocyte count, LDH and indirect bilirubin, iron and ferritin levels, serum cobalamin, serum folate, as well as the RBC folate levels, if indicated. Generally, most patients are treated with cobalamin or folate therapy along with important dietary measures taken. We have come to the end of this topic. Thank you.